Good evening, everyone. Thank you for joining us tonight for the Orthopaedic update. My name is Lydia. I am CPD Program Officer at Central and Eastern Sydney BHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continued connection to water, land and community and pay respect to elders past, present and emerging, and I would also like to extend my respect to Aboriginal and Torres Strait Islander colleagues who might be joining us tonight. And I would like to pass it on to our GP facilitator and local GP, Dr. Claire Stewart, who is member of Advisory Committee for the CPD education in the Inner West region. Thank you, Claire.
Thanks, Lydia. I'd like to welcome everyone tonight. We've got a really interesting talk about bone and soft tissue tumours and the sarcoma service at RPA. So today our speaker is Dr. Daniel Franks, who's an orthopaedic surgeon with subspecialty expertise in orthopaedic oncology, limb salvage reconstruction, and hip and knee arthroplasty. He's a member of the multidisciplinary sarcoma service at Royal Prince Alfred, where he manages patients with benign and malignant bone and soft tissue tumours from all across New South Wales. His practice includes complex tumour resection, custom 3D printed reconstruction, mega prosthetic reconstruction, and the management of metastatic bone disease, alongside primary and revision joint replacement surgery. Research interests focus on innovative reconstructive techniques following tumour resection and improving outcomes after limb salvage surgery. So I'm really looking forward to hearing this tonight. Dan?
Yeah, thanks, Claire. Thanks, guys. As was said, I'm Dan Franks. I'm an orthopaedic surgeon at RPA Hospital and hip and knee surgery, but we have this very niche area among the 4 surgeons that work in my group of treating musculoskeletal lumps, bumps, and malignancies, essentially. So I'd like to go through a few things that I think might be helpful, might be very useful for you, and perhaps a bit interesting, and happy to go through any questions at the end. And hope to fulfill a couple of different learning points for you today. So I'll just go through what a sarcoma is, because even when I started doing sarcoma work as an orthopedic sort of trainee, I sort of wasn't quite sure what it was. I'd really like to let you know how to recognize a concerning lump, which I'm sure you already sort of know, but going over it again might help, and what the evidence base is behind it, what the appropriate investigations are. And that's a bit tricky as well from a primary care physician point of view, because not everything's available to you, or you can't get MRIs as easily or cheaply as specialist can. So I'll go over that as well. How and when to refer is going to be a big thing here, and I hope a lot of you actually have already taken advantage of our service in the area health service, and even if you've worked outside the area health service, because we do service the entire state. And perhaps some other useful information, not perhaps about malignancy, but common lumps and bumps that you might encounter. So what's a sarcoma? A sarcoma is a malignancy that derives from mesenchymal cells, and mesenchymal cells mostly come from the embryonic mesoderm, so the central portion of the the 3-layered embryo, and those cells are destined to become connective tissue, bone, fat, cartilage, blood vessels, fibroblasts, and muscle, and smooth muscle. So pretty much everything that's not like an endothelial lining or epithelial lining, which would be carcinomas. So for every one of these tissues that come from the mesoderm, there is a corresponding sarcoma. So bone osteosarcoma, liposarcoma, chondrosarcoma, angiosarcoma, I don't have to read them all out. Rhabdomyosarcoma. So easy to remember, they all end in sarcoma, but they're all sort of descriptors of the cell of origin. In addition, though, there are a whole bunch, and perhaps even more, that come from tissues. We have no idea what tissues they come from. So Ewing sarcoma, synovial sarcoma, you might think comes from synovium, but that's a complete misnomer. It comes from a cell. We don't know what the origin is, or we know that it's a cancer cell by the time we find it. UPS is undifferentiated pleomorphic sarcoma. That's more a sarcoma probably that's undergone so many mutations it looks nothing like the cell it came from anymore, and spindle cell sarcoma. So it's a very diverse group of malignancies, and as such, they all act in very, very different ways, which is very difficult to tease out unless, and I'd say tease out even when you work in the area. So even for me, I find it very difficult to figure out exactly what's what, and almost every month I hear of a new sarcoma that someone's found or that's just been described, because they're always being added to because of molecular studies and genetics, that we're finding subtypes of these rare cancers. So they're pretty rare. 1% of all adult cancers, the rest being made up by carcinoma and blood malignancy mostly. And also, of course, a lot of you will see lots of skin cancers in your, perhaps as a matter of subspecialty in primary care. But sarcomas only make up 1%, or in some cases, or in some counts, less than 1%. But in the pediatric population, they actually make up 20%. And an incredible statistic that you don't realize, that even though they're rare, they actually are the leading cause of cancer-related deaths in 10 to 24-year-olds. So they're very important, especially in the young. I work at the Children's Hospital as well. You have to if you do this sort of work. And you know, pediatric tumours are one of the very tricky areas, because we're constantly needing to, you know, treat 3 patients, you know, mum, dad, and the patient. As I'm sure you're all aware, in primary care, the same thing applies, and also contend with child growth and development at the same time, which can be complicated. This is a list of all lesions of bone, and this is just of bone. The pink ones are malignant, and the grey ones are benign. And this is a bit old, this graph, but it gives you an idea about the distribution, because you've got age along the top, and you can see that even from, you know, in the first decade, there's multiple presentations of Ewing sarcoma, osteosarcoma, and a multitude of benign things that can all look very much like cancers as well, which makes our job very tricky. There's also this other peak when you get into the elderly, where you have pleomorphic sarcomas and chondrosarcomas, which are more frequent in the 6th to 7th decades. So there's about 100 types, or actually, I think when I started there were about 100 types of sarcoma. Now there's well over 100, and like I say, that's because we're adding new types every year, or let's say new subtypes with different mutations that are only being understood with thorough DNA testing of all of the sarcomas that we take out. And obviously the vast majority, because the numbers are so small, we're talking about 100 types of a cancer, of which make up only 1% of all cancers. Population type studies, or gathering enough evidence on any particular subtype, is very, very difficult to do, you can imagine. And from a research and funding perspective, the burden is relatively low, or perceived to be low, at 1%, that we don't attract the same sort of funding as, you know, the carcinomas do. And because radiotherapy and chemotherapy, generally speaking, in fact, you know, very well, generally speaking, not curative at all, the surgery remains the mainstay, especially for localized disease. Once it has spread, then the decision-making becomes a bit more nuanced, and it depends very heavily on the subtype as to whether they're chemosensitive and radiosensitive, and those can be used as adjuncts. So the treatments, like any cancer, chemotherapy, radiotherapy, and surgery. Generally speaking, a soft tissue sarcoma, so a lump that forms in soft tissue and is only soft tissue, we do surgery first, and then radiotherapy to improve margins afterwards. Some places do radiotherapy first and then surgery afterwards. For bone sarcoma, I think it's reasonable for everyone to understand that the only bone sarcomas that require chemotherapy beforehand are Ewing sarcoma and osteosarcoma. All other sarcomas of bone, we tend to go straight to surgery, again, mainly if they're localized disease, but we know that outcomes are better, and actually these respond quite well to chemotherapy first. and then we do surgery and then chemotherapy afterwards. So a pediatric timeline for most osteosarcomas you see, or Ewing sarcomas, chemotherapy. We then repeat the staging, and most commonly the tumor has shrunk in size or become less avid on the restaging scans, and then surgery, and then post-operative chemotherapy afterwards. I suppose this is good background information for GPs. I know that you'll get a lot of questions, and if you're not comfortable answering these questions from someone who has them, or you come across who parents are distraught and things, I think it's good information to be equipped with, but we don't obviously necessarily expect that discussion to need to happen. But parents will find answers wherever they can, and better you guys than Dr. Google. So just to give you an idea about what happens when we get a referral, because it might help you guys make that referral, and we take whatever we're given, X-ray or MRI or whatever, and within 48 hours we get the referral through our unit. And I'll give you the details of how to make that referral at the end of the presentation. But within 48 hours, the patient's triaged by one of our surgeons, and then we contact the patient with a plan, and usually it's further investigation. Most of our referrals come via other surgeons, but very frequently we get referrals from GPs, which we highly encourage if you're at all concerned about anything. And I'll go through why in just a moment. We then get, pretty much for every suspicious lesion, an MRI, a PET scan, and a CT chest. Again, we don't expect these to have been already done for referrals purposes. We just need enough information to be suspicious to do that. And usually that's an X-ray and a bit of a story. For a really concerning lesion, we need biopsy performed, and we arrange that. We prefer to arrange that. We certainly don't expect that to happen, or an excision of a concerning lump to happen, definitely in the primary care setting, or even with our other colleagues, our other surgeon colleagues, who would be very happy to do that, put them on the end of the list or something and get some sample. We strongly discourage that. We prefer to arrange it ourselves, mainly because there are certain principles that need to be adhered to get biopsies in a way that doesn't compromise further surgeries or the further treatment down the track. And then within about 2 weeks of getting that biopsy, we put it through our multidisciplinary team meeting, and we review the histopathology on one side, and I'll go through who's in our MDT, and then the imaging on another side, and then the surgeons are all there, and we come up with a plan with the oncologists, radiation oncologists, and the pathologists, depending on what it ends up being. And then we can usually start therapy then within 2 weeks thereafter. So that's a rough timeline. We hope to usually be quicker than that. After that, we then, as part of our service, we run a surveillance clinic where we actually get scans every 3 months for the first 2 years, then every 6 months after that, and we keep going out to 7 years. So it's quite a lot of surveillance and quite a lot of scans that we have to get done, and we do all that through our clinic as well afterwards. This is an example of the, I'm sorry about anyone who's eating dinner. There's a bit of this in this talk, so I'll try to warn you. The biopsy, when it's performed, we try to excise the entire biopsy tract plus any tissue that may have been seeded with the biopsy tract with the actual excision. So we need the biopsy to actually get representative sample of the tumor and be placed, the biopsy tract has to be placed in a location where we're going to use, which we're going to use for our definitive excision, so that we can resect the biopsy tract, any contaminated tissue with it. That's why we're very keen on making sure we do the biopsy or order the biopsy ourselves if it's done under image guidance by our radiologists. The main problem for us is when patients don't go down a suitable pathway, and there are a few places that deal with sarcomas and have sarcoma multidisciplinary team meetings. I think we deal with 90% of the bone sarcomas in New South Wales at our unit. But there are other units, and so I'm not, other options are available. But the problem is that when patients don't go through one of those units and through this multidisciplinary meeting, we know that their outcomes are worse. So 30-day and 90-day survivorship is worse. when they go through those units, and overall survivorship is worse. So 5-year disease-free survival is worse as well. So and this has been quite well studied, and as part of guidelines all over the world, a centre effect or multidisciplinary team is recommended. So what we're trying to reduce whoops lesions, and this is an example of one. On the left-hand side, you can see a very small lesion, and probably one you could probably feel. I mean, so you can certainly feel this, and maybe in a rural setting or a more adventurous setting, it might happen in primary care physician surgery, but this one was excised by a neurosurgeon who thought it was a neurofibroma, and removed this with positive margins. So just said, I'll do an excisional biopsy, remove it and we'll find out what it is. Sent it to the lab, and it ended up being a synovial sarcoma. And you can see then on the post-operative MRI scan, what they've actually excised is part of the joint capsule as well, and down into the knee joint, which means that those tissue from that excision is throughout the entire knee joint. So all of a sudden, this goes from a small soft tissue excision to actually this patient, if we need to cure them and get rid of all of that seeded tissue, we have to do an arthrectomy, so remove the entire joint, most of the quadriceps tendon you can see there, and actually replace the distal femur and the knee joint. So it turns into a huge issue. So you can see, I mean, this is a fairly extreme example, but you can see why the outcomes might be worse when these aren't sort of worked up in an appropriate way. Sorry again about this. This is a poor gentleman's back. Again, had a very infiltrative lesion which was seeded through the entire back, and the eventual resection, and it was a very small lesion to begin with, the eventual resection required excision of a very substantial portion of his tissues, subcutaneous tissues and down to muscle. This is a myxofibrosarcoma, which is notoriously difficult to clear. And of course, his resection ended up having to be much wider than otherwise. So they're mostly done by other surgeons. And look, we've had a couple of GPs who've excised pleomorphic dermal sarcomas. So that's a sarcoma of the skin. And that is a little less worrying, and especially in primary care physician in rural settings, where you're cutting out lumps and bumps all the time. And I would wager that many of those GPs and perhaps many people listening have seen many more bumps like that than I have. So I'm not trying to, I suppose, denigrate your clinical acumen at all, because I'd still rely on that more than what I'm telling you. But when they excise these things and it's just in skin, it's less of a problem, as you can imagine, because we can excise the skin and go wider, similar to melanoma excisions, which I know many of you do as well. So it's less of an issue when GPs send us things, and we can usually, there's no harm done to the patient. It's mostly other surgeons. I guess the way that we can get better outcomes from a primary care physician point of view is the time it takes to get to that appropriate referral and get to the right sort of level of care, because often a patient will be referred to another orthopaedic surgeon who will triage them and take their time seeing them, and then we end up getting patients with obvious sarcomas on MRI scans about 3 months after they've had their MRI scan. So if it's something that you think you could help us with, this is something we're trying to improve. Now, the main problem, obviously, for physicians, and so I had this discussion with my wife, who's a GP in Newport, and it was just a discussion, nothing more than that. But obviously, people come in with lumps all the time, and I would suspect, you'd see a soft tissue sarcoma twice in your career. Very extremely rare things, and most of what you're dealing with will only require reassurance. And again, I would rely on your own acumen when sort of teasing those out. There are a few things you can look for, which I'll go through, but we completely understand that you can't necessarily send every single lump for imaging and then to our unit. But I'll tell you how we're trying to help is we're happy receiving any referral about anything. But again, using your own clinical acumen and experience is invaluable. So a couple of years ago in the UK, they launched a public health campaign where it was, is it a sarcoma, and encourage you to think of them as a golf ball because it's about 4 centimeters, 5 centimeters. But the only reasonable paper that looked at this sort of thing, what are the clinical indicators of a sarcoma over a different type of tumor? Whether it's deep, so you should be able to tell whether it's deep as opposed to whether it's in a subcutaneous tissue or in the skin layer. If it's deep, you know, if you can feel it in muscle or moving with muscle. If it's larger than 4 or 5 centimeters, if it's growing, if it's painful. I put an asterisk next to that because the vast majority, in fact, of very large sarcomas present without any pain, without having had any pain at all. And it's always very difficult. It's often I bumped my shin and I got a bruise and it, you know, it hasn't gone away over the last 6 months. And it's, you know, not painful or anything, but it is, you know, a fairly large lump and satisfies those other criteria. And whether it's tethered to deep structures, usually, you know, like a sebaceous cyst, something you can roll around underneath the skin layer is a reassuring sign. But again, none of these, unfortunately, are 100% for sarcoma. That synovial sarc I showed you before was only about 1.5 centimeters wide. So it's very difficult to tease out on clinical reasoning alone. Red flags of a concerning bone lesion. I suppose I've said anything, and I'll explain why in a second, but this, obviously, when you see an X-ray like this, you can tell this is obviously a child. This is the proximal tibia of a child. Physes are open, still growing, and that is not normal bone, obviously, below the physis of the tibia. That is a sarcoma. The only other thing that can cause this sort of imaging is infection, which we get through our unit as well, and we're more than happy to see them and exclude anything nastier. But this is obviously abnormal bone. The issue is that a lot of them are very subtle. So this is the X-rays. These are the X-rays of a boy with osteosarcoma. So the only real indication of anything happening is a little bit of a periosteal reaction. You might be able to appreciate a very fine fuzziness next to the bone on the front anterior cortex of the bone. This is a periosteal reaction, which indicates that something is happening to the bone, causing it to react in this way. And the only other thing is you can see a fairly large soft tissue component bulging out the front of the bone into the knee joint at the distal femur as well. So this can be very, very subtle, very easy to miss. A lot of times patients have had it and they're either not reported or they're reported later and not picked up. And there's changes that can be seen on X-ray that are easily passed off as something else that can be concerning. But if a person's got pain and they've come to you because of pain or a lump and they have any sort of change at all on their X-rays, I think it's reasonable to send to us. And we can put it through our unit, and hopefully the answer is, hey, it's nothing to worry about, just needs an X-ray in 6 months, and we're happy to organize that, or would you mind organizing that? So any change you see on X-ray with a concomitant clinical history and clinical suspicion of a sarcoma or anything nastier, I think it's reasonable to get the advice of us, and I'd hope you'd already be doing that. The other things that are important on imaging analysis, and I'm aware that mostly you'll be looking at X-rays or be getting reports on X-rays to make this initial diagnosis, is how old the patient is, because as we saw, there's sort of a bimodal peak of concerning lesions in bone, whereabouts in the bone it is, and where the lesion is based. So it can be based in the cortex or in the medulla, so in the outside or the inside of the bone. And the borders of the zone of transition is probably the thing that people hear about most in reports and things, and I'll go through what that means in a moment, and whether there's been actually bony destruction in addition to the other concerning findings I've just mentioned. So on that last osteosarcoma X-ray, there was actually no bone missing. You know, it wasn't like it was being eaten away or anything. The type of reaction that you get, and there's this onion skinning, which I'll show you in a moment, and the matrix is the center of it. What does that look like? So there's a lot of different things, and I suppose it's quite nuanced as to what each of these things mean. But there's quite a lot to go through. I'll go through a couple of examples of some of the less known features. So X-ray and MRI scan. So the zone of transition that they talk about, and I'm sorry if I'm telling people that already know this, is the how long it takes to go from normal bone to the lesional bone. So a very aggressive process will have a very wide zone of transition because the change happens gradually. When you look at an X-ray and MRI, what's actually happening is the lesion itself, the tumor, is very invasive or pervasive, and it goes through the interstices of the bone surrounding it and creates a very fuzzy sort of outline. So this X-ray and MRI scan has a very narrow zone of transition because it goes all of a sudden from normal bone to the tumor bone, and therefore this denotes a more benign process. The other things that create the impression of a benign process in this X-ray and MRI are the sclerotic rim. So you can see around the edge of this on the X-ray, you have a sort of a thicker sort of shell of bone. It means that the bone has had time to react to this lesion and essentially strengthen itself despite the lesion being there, meaning that the lesion can't be growing very quickly if the bone's had time to do that. There's no periosteal reaction like I showed before, that fuzziness around the outside. It has expanded the bone, but benign things can expand the bone, like aneurysmal bone cysts and non-ossifying fibromas can expand the bone like this, and they're benign things very frequently seen in children. But this is an example of a benign lesion. An aggressive lesion in the onion skinning I was talking about before was, we always taught that it's like the periosteum of the bone, and kids have very thick periosteum, is trying to contain this lesion that's always escaping that periosteal layer. So you get these layers of periosteum forming new bone, and you can just make it out on that left one, and you can see the concentric rims on the bottom right one. And yeah, for anyone who doesn't know what an onion looks like, there's a picture of an onion too. And that shows an aggressive lesion, as you can see. So onion skinning and a periosteal reaction, when you read that on a report, that's what they're talking about. Cancers and sarcomas aren't the only thing that can cause that. You get a periosteal reaction in the acute phase of, in the subacute phase of bone healing. So a fracture can cause a periosteal reaction, but it's this layered periosteal reaction that's concerning for tumor. And of course, infection can cause the same sort of appearance. Now, this is a slide about ultrasound. This is a poor gentleman who dropped a dumbbell on his thigh and then went to the doctor because there was a bit of a swelling, and they got an ultrasound. The ultrasound said, oh, it's a hematoma, don't worry about it. And then the hematoma kept getting bigger. Now, this is an undifferentiated polymorphic sarcoma. The size of this on the ultrasound initially was much smaller than this. You can see it's wrapping itself around the entire bone. If you go through the slices of this, it goes up to the hip and down to the knee. And unfortunately, this gentleman will require an amputation for this, as it's involving the neurovascular bundle. And it's a shame, but also, I'm quite realistic about how unfortunate it is that this is this very frustrating entity to diagnose when it's so rare. And this could easily have been a hematoma, because he dropped his dumbbell on it. And obviously, you get an ultrasound, and you're reassured by the findings on ultrasound. And in this particular case, this is the 1 in 1,000 that wasn't a hematoma. But I would just caution people to be wary of ultrasound, because the modality itself is very heavily operator dependent, and I think you should use it as to support or refute a clinical suspicion. So use it as an adjunct to what you suspect clinically, and I wouldn't hang a diagnosis on ultrasound alone. If you got an ultrasound of any of the sarcomas that we see, if you got an ultrasound, almost all of them would come back as suspicious for hematoma, because it's just so rare to see sarcomas, and they look exactly the same under the ultrasound. So just beware of them. And if you do get ultrasound, but you're still suspicious, either refer on, or if you think that there might be something else going on, but you're not quite sure, interval imaging with an ultrasound to confirm, as well as an X-ray, of course. But I wouldn't hang your diagnosis on ultrasound alone. So just have a bit of a suspicion, even when you get a reassuring ultrasound report. I'm aware that when it comes to soft tissue tumours, that pretty much ultrasound is the only thing available for GPs to order that can be rebated, but just that clinical suspicion still has to, and your clinical acumen still has to probably drive the whole diagnostic pathway. So I've got a little bit of a run here of how we treat sarcomas, and maybe this is a bit more of an interest for interest's sake. And again, if anyone's eating, I'm sorry, but I'll go through a couple of different things, and you can not perhaps switch off, but this is a bit more for interest than perhaps completely relevant for primary care. But I think it's interesting, and I hope it's interesting nonetheless. So in my very simple orthopedic brain, we take the sarcoma out. We need some tissue around it so that we make sure we get it out. And then we have to put back whatever we took out so that the leg or limb works okay again. And sometimes that means we have to amputate, in order to get proper margins. Or if we take out so much that the leg's not going to be functional again, it's just going to be a dead weight, then it's better to amputate. And these are discussions, obviously, that are fairly nuanced, fairly patient-specific, and we're quite used to having, but we never get used to how different patients are and how they take things. So for a soft tissue sarcoma, this was a synovial sarcoma, which was on the side of, this was a myxofibrosarcoma, which was on the side of the knee. This one started the size of a marble. And so this is the type of picture that I will actually take and send to my plastic surgical colleagues and say, help, ! And this myxofibrosarcoma is a very infiltrative one. It's the same lesion that gentleman had on his back. So you can have these tendrils that extend out from the central nidus of the actual tumor in all directions. Similar to melanoma is more like a satellite lesions that pop up. This is more like direct communication with all of these tendrils. And from something the size of a marble, you can get a infiltration throughout the soft tissues that looks like that. And it's actually impossible to see on MRI and impossible to see when you're operating. So the only way we know we've got around it is histopathology, and that takes about 2 weeks. So we've taken to actually doing these in a staged procedure. So we'll take the lump out, and what we think the lump, and we know we're more suspicious of myxofibrosarcoma because we've done the biopsy. We know that it's got this tendency to extend beyond the edges. We send it to the lab and actually leave this knee as it is, as you see it, leave it open, and put a vac dressing, a suction dressing on it for a week or 2 until we get the results back and they say, oh, it's all clear. Or they might say, oh, it's actually positive at this margin. And we go back, take more, and then we do the same thing again. Because that needs a free flap, and we don't want to do a free flap and then realize we have to come back and take more, of course. So so the plastic surgical colleagues that work in our unit or with our unit, fantastic people, Sarah Loney, Dave Stewart, Alex Poon, the guys at RPA, they're all fantastic, and very keen and happy to drop everything to help us out in these sort of circumstances. It gets a bit trickier when we're talking about bony resections. So this is gentleman's an osteosarcoma of the middle of the femur. And of course, when we remove that and the tissue around it, firstly, we have to remove a reasonable amount of his quadriceps, have to remove the bone as well, and then we have to replace it with something. Thankfully, for the long bones of the lower limbs and actually upper limbs, there are off-the-shelf prostheses. So these are what we term megaprostheses, and you might find some of these in patients who've had revision surgeries and things, but this is essentially a modular prosthesis system that allows us, if we need to replace the entire femur, the proximal tibia, and is off the shelf, so modular. We can make it as long as we want, and actually function very well without having to worry too much about manufacturing something that's custom or anything like that. But because they are modular, it takes a great deal of operative trays and things that you can see in the upper corner there. and it's big surgery, big long surgery. For children, our unit, and before I started, but Paul Stalley and Richard Boyle, who are Richard Boyle still working, Paul's of course retired, pioneered this technique with our radiation oncologist Angela Hong, where the portion of bone that is diseased is removed. We then irradiate that bone with 50 gray all at once. So we pretty much microwave the bone, kill absolutely everything in it. So it ends up being a dead bit of bone, essentially a scaffolding. And then we take the fibula, and our plastic surgeons once again help us with this, because they take the fibula with its blood supply, and we put the fibula in the middle of the bone, and we put it all back in with a plate, and thereby resupplying that dead bit of bone with a blood supply via the fibula. And so then they have to plumb it into the local arteries in the leg. And in doing this, we can actually save growth plates, so the child's leg can still grow. We can retain essentially normal bone. We can eventually remove the hardware, and the patient, the child, can end up with a normal bone. This can only be done when it's outside the joint, because if we irradiate cartilage, of course, it completely dies and degenerative change sets in fairly quickly. But it is an excellent option that we use for children. This is an example of a humerus, osteosarcoma of the humerus. Again, the changes are fairly striking and obvious. There are good off-the-shelf prostheses for the humerus as well. There's a fully constrained prosthesis on the left. It's a ball and socket joint that doesn't allow any dislocation. And then on the right is a reverse shoulder replacement, which is the commonest type of shoulder replacement, but obviously with a larger resection that actually functionally do a lot better than the one on the left. But we need to be able to salvage their deltoid for that to occur. And they're just off the shelf as well. This is a type of prosthesis, in fact, that grows. Now, there've always been growing prostheses. And so, if you have a child, and usually in the lower limb more than the upper limb, because it matters a bit more, but this prosthesis allows non-invasive growth. So it used to be made by a company in the UK, Stanmore, that pioneered this technology. But there's a little tiny magnetically driven motor inside the prosthesis, and the patient comes into your rooms and you measure their limb length however you can. And then you put their arm or leg inside a little coil that looks like a very tiny MRI machine, and you turn it on and you can listen to it with a stethoscope and hear the mechanism actually turning. And then you can measure it either radiologically or clinically to check that you've grown them. And in that way, you can give them a prosthesis that grows with them. It's more important in the lower limb, but nevertheless, this is a very important part when you can't salvage the growth plate and do an extracorporeal irradiation like I showed you before. In very, very young children, what we can do in the proximal humerus is actually just remove the whole thing and take the fibula, which in a very young child, the very top of the fibula is completely cartilage, put it in and plumb it in so it's alive, and just leave a fibula there instead of the humerus, the proximal humerus. When we do that, we know that over time, because of the forces on the proximal fibula, which is now the proximal humerus, and the joint space that it occupies, when we get MRIs down the track, in fact, the fibula starts to hypertrophy. It gets larger and actually starts looking more and more like a humeral head. Now, the function's never quite as good, obviously, as a proximal humerus, but it does grow. So the proximal physis is spared in the fibula, but the child's arm will grow with this. That's all well and good when you're dealing with common bones, but what happens when you deal with the pelvis? Now, pelvis is a very common place, the most common place for chondrosarcoma, for example, which is a type of sarcoma which is only sensitive to surgery. So it's sensitive to surgery. The only thing we treat it with commonly is surgery. Very chemo-resistant, very radiotherapy resistant. And so we need options for the pelvis. The issue with the pelvis is that it has unique anatomy. Everyone's pelvis is a bit different, a unique geometry. The amount we take out of the pelvis is different. And it's not like a tube like the femur. And it has also unique biomechanics. And so what we've also been doing now, and we've got the largest series in the world of these, is actually using 3D printing. So we can adequately model a pelvis and the tumor, and then we can actually 3D print some guides that we can clip onto the bone wherever we need it, so that we know where to cut exactly. This can also be done with computer navigation. But these are 3D printed bespoke guides for a patient. Then we can resect it, and then we're left with a big hole, which is great. We have to fill the hole, as I said in my first slide. The other things that people around the world are doing are a bit strange and not always appropriate. So in America, in some places in America, they don't reconstruct it at all. They, in the top left corner, they just leave the femur to ride up. They end up with a huge leg length discrepancy, obviously functionally very variable, but not great. In the middle one at the top there, that's allograft. So, from the bone bank, so from cadaver. So something that matches the gap that you've had, and you put it in there and fix it with a plate and hope that it all heals up. There's other techniques to fill the void with cement up the top right. The bottom left is an extracorporeal irradiation again. So that's pelvis that's been taken out, zapped, and then put back in. The problem is that they never grow again, and the joint, the cartilage in the joint is completely degraded by that process, and other prostheses. What we use is 3D printing, but unlike what you may have seen, we use sintered metal powder or electron beam sintered powder to make a titanium 3D printed pelvis, which is not filament deposition, which is how we make the cut guides, and what you've seen perhaps in home 3D printers, squeezing out the toothpaste from a 3D printer. This is actually layer by layer. Put a layer of powder down, zap it with electrons exactly where you want your prosthesis to be, put another layer of powder, zap it in the same place, and build up the prosthesis in that way. And so we can design accurately by our cut guides, by our planned cuts, which we've already made, exactly where we want our cup to be, where we think we can shoot our screws, because we need to know what approach we're taking to the pelvis and what angles we can get our screwdriver at, and our drill, what angles they can be. We can plan all those and then fill the void with a metal prosthesis that will function as normal prostheses do, and give us a functional hip. So this is an example of one of the designs that's pretty much been refined to this sort of design. The areas in blue that are highlighted are areas where the prosthesis will attach to bone or will contact bone. And one of the real beauties of that method of 3D printing is that we can actually print down to the micrometer scale, and on a scale that is akin to the lattice or the microstructure of bone. So we can actually print this in the same process, print this on those blue surfaces, and this will be the bone interface and will encourage bone ingrowth. And we've had some we've seen some excellent results from this bone ingrowth through our series. And then the whole thing has to fit into the wound that we've made for it, obviously. So you have to plan for all of these things when you're designing your prosthesis. So it takes, I'll move on from that. Sorry for anyone eating again. And then you end up with a prosthesis that fills the void. And we can also do sacrums and posterior pelvises as well. Obviously, in this case, the patient would have had to undergone sacrifice of their sacral nerve roots in order to put this prosthesis in, especially on the left. I think the top two on the right were salvaged. Another example. So just as a practical summary for suspected sarcoma, refer to an MDT early. We need to biopsy correctly. We need to stage it properly. Staging, obviously locally we do MRI and X-ray, and then systemically PET scan and a CT of the chest, as most sarcomas will metastasize to the chest first, which is why we don't grade. I should mention that we don't grade sarcomas in the same way, or stage sarcomas in the same way as carcinomas. We don't have 1 to 4. We pretty much have localized and metastatic, because if it has spread, it's spread to the chest already. So there's no point in talking about lymph nodes and things, or local, loco-regional spread. We need to discuss it in the MDT is probably the most important thing. And to be honest, I wouldn't know what to do without my pathologists, radiologists, and oncologists to tell me exactly which way to point the scalpel. But we rely very heavily on that team meeting. And obviously we preserve function wherever possible, but if we have to choose, obviously the tumour trumps everything, and if we have to amputate, we do, you know, and it's heartbreaking often, and especially if it's a child, but often children are very resilient, more resilient than adults are, and they deal with it very well. But we have to make that decision early and properly, and then we have to just tailor systemic treatment depending on exactly what sort of a thing we're dealing with. So that's sarcoma. I've just got 3 examples of things that you might come across in the benign realm that might be useful. I'll just go through really quickly. I think I've got 10 minutes left. Lipomas, I think probably a lot of sort of procedural primary care physicians will have excised more lipomas than I have, because they come in all the time, and when they're superficial, it's not an issue. Superficial lipoma or a sebaceous cyst or something that you're happy to remove, I can't sit here and say, look, all of those should come to our meeting. You know, that's plainly ridiculous. I think if you have the clinical nous to tease those out and the experience to know, then I think it's very reasonable. I just, if this talk does anything, then I hope maybe it just keeps that little nagging bell in the back of your mind if you see something that doesn't quite fit. Enchondromas, which are completely benign things, and then PVNS you may have read in reports. That's a very common thing to get back in an MRI report. So I'll just go over these quickly. So obviously lipomas are just big fatty lumps, and a lipoma by definition is benign. There is an entity called an atypical lipomatous tumor, which is just slightly more aggressive than a lipoma. I say aggressive, it has a mutation in it that allows it to mutate further. So it has pre-malignant potential, but it itself is not a malignancy. And when we resect them, there is a much higher rate of recurrence of an atypical lipomatous tumor. And the problem is that on MRI scan even, and certainly on ultrasound, they're indistinguishable. But there are a few clues that can point you in the right direction. One is that you have fibrous septa that are you see within. So this is like a coronal section of an MRI scan on the left, T1, and then T2 on the right. You can see that this fatty mass, which is on the side of the pelvis, is underneath the abductors, and it's got a lot of this internal. It's not like a simple lipoma like that last one. It's got these internal sort of septi, we call them, little fibrous strands, and you can see that on the contrast film on the right, those actually enhance a bit. It's also very large, which is another clue, and it's very deep. You know, it's deep to muscle. So these are all clues that it could be something else. And it's not uncommon for us to see an atypical lipomatous tumor and actually see a nodule where you actually have dedifferentiation into a liposarcoma right in the middle of it, because they do have this malignant potential. So if it's deep, if it's large, if it's growing, if it's got thick septi on the MRI scan, which I don't expect everyone to have access to that straight away, of course, and the septi enhanced with contrast, then we're more suspicious of an atypical lipomatous tumor, and that is something that we usually do recommend comes out rather than a lipoma. If we see a lipoma and it looks as benign as that first one, we're happy to wait and watch and check that it's growing or not growing before we recommend surgery. Obviously, they're a very common sort of a lump. Cartilage tumors, I encourage people to think of them as sitting on a continuum from an enchondroma, which by definition is completely benign. And that's just a bunch of cartilage cells, like you see down here on that picture, which is sitting there in the bone, sitting there happily and not actually moving, not changing, nothing. And this is a continuum all the way up to chondrosarcoma and dedifferentiated chondrosarcoma, which are obviously malignancies. The intermediate lesion entity is an ACL, or atypical cartilaginous lesion. And an ACL looks almost exactly the same as an enchondroma, but it's growing, or exactly the same as an enchondroma, and it's pierced through the cortex of the bone in one spot. Enchondromas, though, are most commonly seen as incidental lesions. Usually you get an X-ray of a chest and you see it in the proximal humerus, a very common place to see it. And it's very frequently reported on those X-ray reports, and this is something that needs surveillance. Usually, if we see an enchondroma and it's quite a benign thing, it depends a bit on the age, but we will get surveillance, or we can often send out a referral or a letter that will explain exactly what the patient needs for surveillance to the surgeons that send these to us, or the GPs that send them to us. And usually, if it's as benign looking as that one, then you can get surveillance X-rays in future. Especially in the elderly, which have this rate of dedifferentiation of an atypical cartilaginous tumor to chondrosarcoma and dedifferentiated chondrosarcoma. And this is another really difficult area, because we don't actually know how many people are walking around with one of these in their bone. And so we don't know what the incidence of dedifferentiation is. All we know is that the patient comes in and they've got this huge chondrosarcoma that's extended off the side of one of these enchondromas. And and we can see that when we do the histopathology, the dedifferentiation pathway from benign to a malignant state. It's difficult to know. I've got one of these in my distal femur I didn't know I had until I got an MRI of my knee after an injury. So they're very, very common. This is an example of an atypical cartilaginous lesion on the left. You can see it's the same sort of animal, but it's and sorry, these are two different people, so we didn't excise it. But the one on the right, one on the left, in that right femur, that's an enchondroma. But when we first saw it, we thought, oh look, it's pretty big. It's also sort of nibbling away at the endocortex. It's pushing out on that endocortex, but it hasn't come out of the bone. We don't know if it's growing, so we'll just watch it. We ended up watching it, and it grew by about 1 centimeter over the course of 2 years. So by definition, it's something a little bit more aggressive than an enchondroma. So we can go in and actually scrape that out. So we can don't have to resect it or anything. We can scrape that out, freeze it with liquid nitrogen, pack it with bone graft, and put a plate on it so they don't complete a fracture. And in doing that, we've treated it, and that's the appropriate treatment for an atypical cartilaginous lesion. By contrast, the one on the right-hand side there is a chondrosarcoma. You can see the little cartilage thing in the very middle. That is cartilage, and that probably, if you took that in isolation, it looks similar to the one on your left. But you can see beyond that, on the edges of that, it's formed a chondrosarcoma. So that's areas where that cartilage is pushed out into the soft tissues around it, pushed out beyond the bone, and is obviously a malignancy. So all of these lie in a continuum. You'll mostly catch them or be reported on as an enchondroma at the beginning, but nevertheless, we do surveillance on these just to make sure we don't end up like that picture on the right. PVNS is something you'll get reported on in MRI reports, and we see a lot of PVNS through our clinic as well. It's a benign lesion, but it can be locally aggressive and locally destructive. So it can eat into bone, it can eat into surrounding tendons, and it mostly, the way it causes an issue is that it is a very, very friable lumpiness of the synovium, of the actual lining of the joint. It's a proliferation of that, and because it's lumpy and friable, it bleeds. And the P of PVNS is pigmented villonodular synovitis, or tenosynovial giant cell tumor, which is a TGCT. But P pigmented, when you open these up and have a look at them, the recurrent bleeds into the tumor itself creates these pigments. They call them autumnal hues. So they're dark reds and browns and yellows. These are degradation products of hemosiderin and blood breakdown products that stain the tumor. And mostly people come in complaining of recurrent swellings for no good reason, often young people, recurrent swellings for no good reason. And it's something that they can be very symptomatic, they can be completely asymptomatic. And if it's not causing any problems, we can wait and watch and leave it and just check how it's going. MRI scans, surveillance MRIs, which we do through our clinic as well. But if it is symptomatic, then the patient needs the lining of the joint removed, which is obviously a huge undertaking. This is MRI. These are two different patients exhibiting two different forms. There's two different forms of PVNS. One is nodular form, which is like a little tiny mushroom that pops up in one place. And when that happens, and that's on the left, and you can see it just behind the femur there on the top, this area. And when that happens, it's very easy. You can just go in and cut the stalk off, and actually cure rates are pretty good for that. The problem with this one is that you'd have to go through the back of the knee, which is something we do very frequently in our unit just because of the nature of the work we do. And so we get referred a lot of these where they're in the back of the knee and otherwise difficult to resect. The other form of PVNS, which is on the right-hand side, is diffuse form, where the lesion actually extends through the entire joint. You can see it's in the front, it's in front of the ACL, it's through the back of the capsule there, it's up into the suprapatellar recess as well, and that's very difficult to cure because you just simply cannot get everything out. You do your very best and hope that that is, removing enough is enough to stop the recurrent bleeds into the knee joint, but it is a very difficult thing. Nevertheless, we see a lot of these through our clinic as well. So just to finish off, just about our unit, the bone and soft tissue sarcoma unit, we look after all of New South Wales pretty much. We undertake a lot of education to stop those whoops lesions, and we're pretty good for orthopaedic surgeons, because we are all orthopaedic surgeons, a core group. Obviously, we have plastics as well, but we run education sessions for them because they have the potential to be the worst offenders for whoops lesions. But we take referrals from anybody. So orthopaedic surgeons know us, so they send a lot of stuff to us for the reasons I've outlined. But we're very, very happy to take referrals from anybody, including primary care physicians. In our MDT, we've got medical oncologists, radiation oncologists, and musculoskeletal radiologists are worth their weight in gold, because they really tease out the nuances of these lesions, which, sometimes it's absolutely impossible to tell what something is unless you biopsy it, and being able to tease out those nuances as radiologists is really, really the most valuable part, I think, of the unit. Surgeons, of course, there's 4 of us orthopedic surgeons. We have general surgeons, plastic surgeons, and spine surgeons that we lean on when we come up with something that requires a combined approach. Our pathologists are world class. They literally write the textbooks for this sort of thing, and I think collaboration in our unit is second to none worldwide, in fact. We have a lot of CNCs who do a lot of the legwork, a lot of contacting patients. They do a lot more than we can possibly hope to do in terms of settling anxieties and things. And I think the first thing you'll get asked if you do come across something with a concerning lump, or the word sarcoma has been mentioned in a report somewhere that you've gotten a scan on a patient, that the CNCs will be able to speak to them and explain to them the process and the path, and really are the first point of call, and fantastic. We also have social work and palliative care as part of our group. So we manage all of that nasty stuff, but we also do a lot of opinions for radiology. If we're not quite sure, if our surgeon's not quite sure, we can put it through our meeting, talk about it, and then send a letter back saying, look, we think it's this, this is what you should do. So it doesn't have to be us managing it, but we can generate that opinion. We can do the same thing with the histopathology if there's concerns or questions about that. We do surveillance, obviously. Because of the type of resections and then replacements that we do a lot of metastatic disease, and the oncologists are getting better and better at controlling disease from carcinomas and blood malignancies for a very long time, which makes actually metastatic disease a growing portion of our work as well. Obviously, if someone's doing very well and systemically very well controlled but has a lesion in their femur or their tibia, then we need to do a very similar type of operation on that person as someone who's got a primary bone cancer. And then also very large revision surgery. So people have had hip replacements or knee replacements in the past and need something much larger because of the amount of bone destruction from having had that, or infections around that. Those things get sent to us too, and we encourage all of those things. We're happy to see them. So anyone, absolutely anyone, can refer. So back to the problem with the GPs. I think that it's really hard for us to expect that you're going to approach everyone who walks in the door with the same suspicion that we approach people, because by the time they get to us, obviously there's already a high index of suspicion, having gone through at least one other doctor before. And so it's hard for us to expect that you'll do that. And certainly every single lump and bump that walks into a GP surgery, in New South Wales, that's certainly beyond what we could manage. But I would just say that there's no judgment. There's no, this is not something that's appropriate for us. The way we help you knowing what to refer on is just to say, just send us everything. It's cool. We'll sort it out. And hopefully the answer, hopefully for everyone, patient, us, everyone, the answer is, oh, look, it's nothing really to worry about. We think it needs this, or, we don't need anything else. Or if we just get another scan in 6 months and it looks the same, we're happy. So we understand that. We also understand that, if you take something out and you're not expecting it, that a lot of things can look completely benign when you see them. You take them out and there's something else. And again, we completely get that side of things too. So we see and help with all sorts. So that's a bit about the unit and about what we do. But these are the important details to sort of keep. And I hope we've already helped some of you out and hope to help a lot more of you out as well.
Thanks so much, Dan. That was really interesting. I didn't know at all that there was so much like 3D printing and all that sort of stuff that can be done. So that's amazing. If anyone has any questions, if you pop them in the question box, I'm happy to facilitate a Q&A with Dan. I'll ask a few first because I've got a few. How many patients are you seeing per year? Like if it's New South Wales wide, like how many people are you seeing per year with sarcoma?
With sarcoma, so we recently got our numbers for this, but we get about 90 referrals a month through the unit. But the vast majority end up being benign or being for surgery and then surveillance or just surveillance. So brand new sarcomas a month, probably about 20, something like that. And then that, not including the sort of the other malignancies or other sort of specialized orthopedics that we do. But interestingly, that number is increasing quite substantially since we've started this unit in earnest. And we've always run this sarcoma unit and always happy for anyone to refer to us. But the unit's taken off really in the last sort of 3 years since we've gotten the CNCs on board. So we have clinical nurse consultants who can drive a lot of that for us in ways that we couldn't before. And that's actually already increased our numbers through clinic. And we're catching a lot more before they become a problem. And we also actually do not know why we're getting more sarcoma referrals, but we are. Mm-hmm. And we don't know where they would otherwise have gone before. It's not a population growth thing. We're not quite sure why, but it's increasing.
Mm-hmm. Yeah. And do you know how most of these patients present initially? Like, do they come with a lump or pain or?
So the bone sarcomas generally come with pain.
Yeah.
The thing that happens in bone, so kids with osteosarcoma, osteosarcoma, Ewing sarcoma, they come with pain. I got tackled at footy and actually the pain hasn't gone away in 3 months. A lot of big sarcomas will just come with a lump. Some sarcomas, when they're near a joint, synovial sarcomas, although they're not of synovium, happen near joints. And so near joints, if you think about it, apart from the hip, they're mostly superficial and you can feel them when they're quite small. So they'll come with a small lump. Very rarely, nerve or vessel issues. If the mass is so large that it's compressed vessels or nerves, that can happen as well. And
do they are they quite aggressive? Do they grow? Like if they're soft tissue sarcomas, are they like it's something someone comes and says, I noticed this and it's got double the size in a month, and that's a red flag? Or
so that's really worrying. Some grow because they just grow because the cell number increases. Some grow because they bleed into themselves. So if a tumor, part of the grading of a tumor, so not staging, the grading, how aggressive something is whether it's got necrosis in it. And you can see that on MRI, you can see it when you biopsy them. If it's got necrosis, it means it's growing so fast that it's outstripped its ability to make blood vessels. And those actually can bleed as well. So these things can get really large because they've bled into themselves, not because the number of cells has necessarily increased that much. But a really rapidly growing thing is very concerning, but it's hard. What do you do with an older person who's on blood thinners, who've bumped their leg and they've got a large mass there? that's a very common story. We thought it was a hematoma because he's on warfarin or Eliquis, and actually, it's just still there and still growing. And then, someone gets an MRI, and then, hey, what do you know? But then there's some sarcomas, epithelioid sarcoma, and sometimes synovial sarcoma, as I've explained. They can sit really small and be there for ages, and then all of a sudden take off. So they can say, "Oh, I've had this lump on my hand for actually like 5 years. I never thought anything about it, but it's recently started to get bigger." And that's a sarcoma, It's just, and so this is the heterogeneity of sarcomas. There's really, in terms of guiding you clinically, it's just minefield.
Yeah, no, and you're right. Like, it's tricky because we see people all day who come with, like, I saw a bloke just this afternoon. He said, "I've got this lump in my groin, like in my sort of upper thigh. It's been there for a while. I don't think it's doing anything." And I was like, "Oh, I'm pretty sure that's a lipoma," but now I'm worried that it's not.
I don't mean to worry anybody at all, and I don't know how to. I actually don't know what to say in this sort of a talk, because you guys see it every day. I'm very well aware of it every day. Like I said, I talk to my wife about this stuff all the time. I actually, preparing for this talk, I said, what do I say to people? Like, how do you? And so same with public health. I was asked to write a letter on the Cancer Council page, and I don't know what to say to people. What's a sarcoma? It might be painful, it might not be painful, and it might be a lump that you can feel, but you might not feel it, and that can be cancer. Everyone's going to freak out,
Yeah.
It's very, very, very difficult.
Yeah.
So, the suspicions are mainly, if it's growing and you can't explain it otherwise, and deep and large, that's something that I think I worry about.
Yeah. And in terms of like imaging, are you people being sent with these found incidentally on imaging for other things?
Yeah, so we do have incidental omas, we call them.
Yeah.
But yeah, they get an MRI for something else, or even they're getting staging with a PET scan for the breast cancer, and they've got actually a synchronous sarcoma somewhere. Mostly it's a lump coming with an ultrasound and seen by an orthopedic surgeon, so it's appropriately referred on to that orthopedic surgeon. Orthopedic surgeon gets an MRI scan. They rely on the report, sometimes look at it themselves and go, "Oh, actually, this is something else," and then send it to us. That process, though, takes quite a long time. But, it's fine. And so if you have a trusted orthopedic colleague who, and look, hand surgery and foot surgery, generally speaking, they're surgery specialties of lumps. They do a lot of lumps, ganglia from hands, lumps and bumps on feet. And so even for them, I say, look, it's hard. We can't ask you to send us every single lump in the hand that you get. It's not feasible either. And we do get a lot of, hand surgeons that send us sarcomas, because they've inadvertently taken one out. So that's very difficult. But we're happy to get an ultrasound, referral with an ultrasound and a reasonable story. And then we do the rest. Our CNCs contact them, "Hey, your MRI's on this day. We'll let you know what we think about the results."
Yeah. There's a couple of questions now in the Q&A. So the first one is sarcoma the most common bone cancer in bones?
So I would say no. I'm thinking about the technicalities here, but primary bone tumor by definition is a sarcoma, unless you're talking about hematological malignancies, in which case obviously multiple myeloma is more common, and we see that a lot. Lymphoma of bone as well. We see a lot of lymphoma of bone because it can look exactly like Ewing's sarcoma. And their hematological malignancies are more common than sarcomas are. And then, bones, that 1% is all of sarcomas. Bone sarcomas is even less. So I would say the most common malignancy, so the most common cancer in a bone is metastatic disease by far. So in a certain age group, if someone comes in with a bone lesion, it's metastatic 1, 2, and 3. Even if they know no history of primaries or anything, they come in because they got pain in that bone, and that's the clinical suspicion from the start. Everything else is probably hematological and in that age group as well. And so it's fairly uncommon to get that. And even in kids, it's not the most common bone lesion, right? So a bone lesion, it's much more common to be something called a non-ossifying fibroma, which is the most common lesion of childhood, which resolves by itself. And then we get sent a lot of those too, and that's fine. We reassure the patient and reassure the family and jump in if we need to. But yeah, so no, it's not the most common anything.
And in sarcoma itself, is it more common in the long bones? Is it more in like arms and legs, or it doesn't really matter?
So chondrosarcoma is flat bones in the elderly. So the pelvis and scapulae, chondrosarcoma. Ewing sarcoma can happen in the diaphysis, so in the middle of the bone. In the metaphyses, osteosarcoma are more common, most commonly at the distal end of the femur, very common. So the site gives you a bit of an idea, but they can happen anywhere. And we see Ewings in the pelvis all the time. Osteosarcoma in the pelvis less commonly. Spine tumors, that's a rarity as well, but very, definitely happens,
Mm-hmm.
These are the nuances of the imaging.
There's a question here that says, I had a patient who had neoadjuvant and then concurrent hormonal therapy plus external beam radiotherapy for prostate cancer. Then years later developed a rectal mass, which was an angiosarcoma. Is sarcoma a long-term consequence of his previous radiotherapy or prostate cancer treatment?
Yeah, it is. And one of the ways, so the consent process for radiotherapy is a very small chance of radiation-induced sarcoma. It is, yeah. I've had multiple patients with that. So people used to get whole body irradiation for various things. And so those patients are at lifelong risk of it. And we've seen radiotherapy occur in, and usually when they occur, they're usually an undifferentiated pleomorphic sarcoma, angiosarcoma as well. And they are difficult. They're aggressive, they're nasty, and obviously they're occurring in a radiotherapy affected field. Surgery is much more difficult. And also, once they're radiation induced, we can't rely on radiation afterwards. So we don't do radiotherapy for radiation sarcomas afterwards for obvious reasons. And so, they're very challenging to treat. But that's part of the consent process for radiotherapy, generally speaking. Very uncommon. And the radiotherapy that people get nowadays is different and more targeted and obviously minimizes those risks, but it is always a risk.
There's a question here about like fine needle biopsies of subcutaneous lumps and whether we should order them, because I thought that was really interesting what you said about making sure you biopsy them correctly because otherwise they seed.
Yeah.
Is that like something that is unique to sarcomas? Because like we order biopsies of breast lumps all the time and it doesn't seem to be so much like an issue that we think about.
I know. I suppose the difference is the difference is with breast lumps. Firstly, there's adjuvants that you can rely upon: hormonal therapy, chemotherapy, and radiotherapy. And there's obviously a wealth of research to support those things as adjuvants. I've got to be clear: when the biopsy tract, a lot of papers for sarcoma have looked at the biopsy tract, and those papers have looked histologically at the biopsy tract to look for seeding, and it's not been shown to be a significant concern. We've had a couple where you excise the biopsy tract and you can see lesion in the biopsy tract. Whether it's seeding or whether it's direct extension is a bit tricky to know 100%. It's mainly because when a sarcoma occurs in the middle of a thigh, there's obviously multiple ways to get down there, including going straight past the vessels, which you don't want to. Because if something occurs in that area, not that the likelihood's high, but the consequences are very high. Whereas, and I don't know a lot about breast biopsying, but obviously because it's all fairly superficial compared to the other vital structures, less concerning and more easy to catch and treat, potentially after that. But I should make it clear, and this is a pet peeve of Richard Boyle, and we all say this: never ever fine needle biopsy any suspected sarcoma, because a undifferentiated pleomorphic sarcoma just has nasty looking cells, and that's all you get from a fine needle aspirate. We need the architecture. So all of our biopsies specify underlined and in bold has to be a core biopsy. And that's a harder thing to do in rooms, and you need special, you need the core biopsy needle. So if you're biopsying something because you're worried about it, fine needle aspirate's not going to get us there.
Mm.
It's not going to rule it out, and it's not going to tell us exactly what it is. So it needs a core biopsy. So if you're worried enough to biopsy it rather than excise it, so if you're comfortable excising it, obviously a dermal thing, subdermal thing, you excise it. But if you're thinking about worried enough that it needs a biopsy, it needs a core biopsy, not a fine needle aspirate.
Mm-hmm.
Yeah.
Mm-hmm. There aren't any more questions. I might just wait a couple more minutes and see if any more pop up. But I mean, you've gone through pretty much all of my questions, I guess. I suppose the other thing I was going to ask is, are we doing less amputations overall now because of all these other sort of limb sparing techniques?
Yeah, when I say now, I mean, now compared to like the 60s or 70s.
Well, yeah.
so yeah, definitely. I mean, you go through runs where you just have to make the hard call. And look, it's especially with the Ewings and the osteosarc, the chemotherapy regimens that they've got now are reasonably well researched, and there is that window of operative optimization helps us to do limb salvage, and things like growing prosthesis and new techniques and things make that limb more functional once we have resected it. But we're definitely able to do more resections now compared to back in the day because of the adjuncts and their better imaging. We know exactly where it is. We can see the vessels better. MRI resolutions improve. PET scans are another thing that we can see. So definitely all of those things contribute to us being able to do more limb salvage.
Mm. There's a question here about if you see sarcomas on the scalp.
Yeah. When that happens, we usually get our plastic surgeons to have a look. And there's an entity called dermatofibrous sarcoma protuberans, which is a common dermal lesion, which has infiltrative margins, and it's the type of lesion where you keep taking and eventually, have to get plastic surgeons involved anyway. Relatively frequently, that goes straight to the plastic surgeons, but we certainly see them and work them up. DFSP, which is what it's called, is not in itself considered a sarcoma anymore, I think, in the current DSM, but it can can dedifferentiate into fibrosarcoma within it. So yeah, we see that. And look, scalp, we see all sorts of sarcomas. I mean, the sarcomas can be of anything. I remember a chap with angiosarcoma through his entire scalp. These are the sorts of things that can respond well to chemotherapy and radiotherapy as well. So yes, we see them as well. It's any tissue anywhere, it's hard to, there's no rules. They're anywhere. The reason orthopedic surgeons are doing it is because, in the unit, is because we see it frequently in the limbs, and that requires salvage and orthopedic sort of, reconstruction.
And did you say before that the unit also does, like if someone's got a big bone metastasis from something else and they need you, so that those patients can come through the sarcoma service as well?
Absolutely, and it makes up a very large portion of what we do. A lot of people put rods through metastases. You stabilize the bone rather than resecting the metastasis and doing it. So renal cell cancer is a classic example of a tumor where if you have oligometastatic disease, so you have the renal cell cancer and the diseased kidney, and then only one or two other spots, including bone, whether you can actually cure them because it tends to only metastasize in a very few number of places, by doing a proper tumor principal resection and reconstruction. And so people with oligometastatic renal cell carcinoma, we usually give the benefit of the doubt and do a tumor resection like it's a primary bone tumor, and the cure is the goal. And the nuance of when to do that sort of operation versus when to just stabilize it so the patient's out of pain and no fracture risk and things like that, very difficult often to know which one is best. We contend with that a lot.
And just to confirm, so the sarcoma service, all referrals go through you for children as well through RPA, or do they go to the kids hospital?
So we don't mind which one they go through, and if they through our unit, we pretty much liaise with Westmead Kids straight away, which is where our sarcoma unit. We do it at both Randwick and Westmead. But if we get it through our sarcoma unit, we sort of contact them straight away, because the workup and the initial sort of biopsy, MRI and everything, if they're very young and they need a GA for an MRI, for example, we do it all in one go, and that takes a bit of coordination on the ground over at Westmead, and then we usually operate on them over at Westmead Hospital. It's a lovely new hospital.
And I'm going to finish with one more sort of clinical scenario question about a patient who presented with a few cutaneous lesions on the abdomen. The GP excised one, and the pathology came back as an angiosarcoma. Was then referred to an oncology surgeon who excised all 5 of the lesions, but then 3 months later the patient came back with disseminated cutaneous angiosarcoma. Is there something that would have been done differently if they came through the sarcoma service?
Yeah, well, I guess, look, that may have gone through an MDT, and it may have had all the appropriate staging and everything. So I can't comment on the appropriateness of that, the treatment there. Angiosarcoma and cutaneous angiosarcoma that's multifocal, we tend not to try to resect completely, and it responds reasonably well to radiotherapy, actually, depending on the age of the patient and the location. But I'd be interested to see whether it was genuinely disseminated on PET scan and things like that. There are certain adjuncts that we'd probably use if there were multiple areas. I mean, the suspicion obviously is that there are other areas you just can't see that you're not resecting, and so why resect anything? We need something else to fight this thing, I guess. But look, I don't know enough about the patient, but that's a sort of discussion that we would definitely have between like 3 or 4 people in the MDT about what it is.
So I think you have successfully got to the end of all of your questions. So no, I'd just like to say thank you, because it was really interesting.